Recording in progress.
Hello everybody. Welcome back in our second day in our laparoscopic colorectal workshop. First, I'd like to welcome our chairpersons, Professor Ahmed Shukri, Professor laparoscopic surgery, Professor Wael Lolah, Professor of Surgical Oncology, Professor Mus'ad Anwar, Professor of Surgical Oncology, and Professor Mohammed Mamdouh, Professor of Surgical Oncology at Al-Azhar University. We are honored that we are joined by a great and well-known laparoscopic colorectal surgeon, Professor Werner Breurer from Switzerland. He is the head of the colorectal surgery at Cantonal Hospital, St. Gallen, and he has an early focus on minimally invasive techniques since the late 90s, including single port and transanal and transvaginal surgery and robotic surgery. He is the organizer of the European Colorectal Congress, and he is the president of Foundation of Gastrointestinal Surgery Davos. He is one of the members of the national and international societies, and he has many publications. Please welcome with me Professor Werner Breurer. He's going to talk today about transanal total mesorectal excision of the rectum. Professor Breuner? Professor Breuner.
Thanks a lot. Yeah, hello. Thanks a lot for that nice introduction and for the invitation to join you. Best greetings from Switzerland. Actually, it's snowing outside, and I hope you have some warm weather in your region. So my topic is today to talk about transanal TME, and I hope you can see my screen now. And I will give you some brief introduction in the next 30 minutes about the transanal approach to rectal cancer surgery. Of course, we use the transanal approach also for other indications, but today my focus will be on rectal cancer surgery. If we look back on more than 100 years of curative surgery for rectal cancer, you will see that there were some starting with posterior approaches where the recurrence rate was 100% and the 5-year survival was 0, until Miles in 1908 came up with APR and unblocked lymphadenectomy. So that was the time when we learned how to make the resections better. And then a big anterior resection group always making the surgery better was coming up from 1910 on, which were called the anterior resections with anastomosis or without. And you see that's all about going more lower, like Parks did in 1972. But up to now, the most important works were done by Bill Hield, and you know them, which was in the early 80s, showing us how to do a proper TME, meaning a total mesorectal excision. That was done in 1991 for the first time in a minimal invasive state. So what we suggest today and what we want to reach is a 5-year survival over all the T and N stages over 70%. We want to have an APR rate below 20%, and we want a recurrence rate below 5%. This is what we are aiming for, and we should not forget that if we introduce new techniques or we come up with new instruments we use. You will also see that in 1985, Bues in Germany started with transanal endoscopic surgery. First the polyps, but now also, of course, the malignancies are resected via transanal endoscopic microsurgery if these are only polyps. So this mixture gave us some options on anterior and posterior approaches. Mainly all the literature is about the anterior approaches coming via the open approach of minimal invasive approaches, but there are still some posterior approaches which we kept. These are the works of Bill Hield, you know them, in the early 80s, how to do a total mesorectal excision, which is meant for the lower 2/3 of rectal cancer. There was another important publication also in the early 80s, meaning how good are surgeons and how high the impact on a surgeon influences the patient's further course, meaning the oncological perfection. And you all know Phil Quirke, who showed up that the local recurrence can be predicted if the surgical resection was inadequate. And now we mainly have the grade 1 as the best and grade 3 as the worst, meaning that grade 1 and grade 2 have similar further course for the patients. But if we produce a grade 3 mesorectal quality, then we surgeons put the patient in the next tumor stadium. And these are, of course, things you know and you will get out from your pathologist, meaning the circumferential margin, the distal resexal margin. It should always be like a complete specimen, and we aim to get a Quirke score best, meaning nowadays the 1. In other countries, they use Mercury score, but the meaning is the same. Of course, it should be an R0 resection. And let me add something we learned over the years. Of course, during surgery, we always want to avoid tumor cell spread. So 40 years after these publications in the early 80s, we have a lot of options from open laparoscopy or robotic to transanal. And you will agree that the robotic and the transanal are the most disruptive techniques because we do other things we were not able to do before. We learned a lot how to do that. And nevertheless, we need some requirements to do the proper TME. So the one is the technical challenge. Are we able to face that? More surgeons are now thinking about oncological perfection. But last but not least, it's also the functional outcome. And patients do think a lot of functional outcome, which comes in the surgical community only since 10 years around. So the first publications on low anterior resection syndrome came up 12 years ago, so that's not a long time. Bill Hield said that there are, of course, many ways of doing an operation badly, and he proves that with one publication that more than half of the recurrence is due to a residual mesorectum. So people think they do a total mesorectal excision, but they left mesorectum behind, and that has a much higher chance to come up with a recurrence. So if you look on the first publications of transanal TME, that was in February 2010, and that's of course Antonio Lassi, but I want to point out that it's also Ricardo Zoran in Brazil who started that maybe even earlier than Antonio Lassi. So since 14 years, we are dealing about the transanal TME. What are we doing? There is one abdominal part, meaning the colorectal mobilization, the vessels, the flexure mobilization, that is done minimally invasive from abdominal and not transanal. And then there is also a transanal part, meaning the exact distance from the tumor, the distal rectal mobilization, and the TME could be done from below. So that is what is done by the transanal part. You can integrate the nodes concept, meaning operating via natural orifice, and also take the specimen there, but that's not the major aim of the transanal part, is the resection, not how you bring out your specimen. This is videos of our OR. You see we are doing complete parallel working. So the one team is operating from transanal, the other is operating from the abdominal part, and there are only few minutes you cannot work at the same time, and that's the time when you do the purse string suture of the transanal part. So that's the only time the one abdominal team has to wait, but the transanal team has to work, and then everybody can work at the same time. It's parallel working. That means that your time of operation goes down for 1 or even more than 1 hour over the whole operative time. This is our approach. We mainly do a single port access at the stoma site if we need a stoma, which is not in all patients, but if we do, then we put a stoma site, the single port system. We have one additional 5 millimeter trocar. Maybe we use more if necessary. Of course, that's not forbidden, but it's kind of reduced port abdominal wall surgery, so we don't want to harm the abdominal wall too much without compromising oncological results. So what is the abdominal team doing? They can do everything above going down to posterior S3, and you see here on the screen, on the scheme, very nice, the sacrum has a band at S3, so it's very easy in all the patients to come down to S3, and the same is true for the anterior side. You can easily go down to the upper part of the prostate, and then it's going to be difficult. And you see the green line is what's done by the Transanal team, which is easier to come from below. So the abdominal team stops at S3 and should stop before opening the anterior peritoneal fold, because this can easily be done if you approach from below and then you just open the peritoneum. You are already in the right plane, so that's easier to protect the mesorectum if you come from below. The transanal part is done by a Lone Star and then a special single port system. And there's many systems on the market, but the only which is used very much and has a lot of advantages is the jail point path, where you can use 3 or even 4 trocars. You have a protection system inside, and you can start from transanal endoscopic way easy if the tumor is more than 4 centimeters above the sphincter, or even if it's 2 centimeters above the sphincter, you can bring in your system and start direct endoscopic. If it's lower, of course, you have to start intersphincteric, either partial or even complete intersphincteric resection. So this will be done open then until you have 2 or 3 centimeters above the sphincter. You close the rectal stump complete, and then you bring in your endoscopic system and you proceed the same procedure as you would do if it's a little bit higher. So what is important is the first thing you can see here on the scheme, and I would just stop a little bit the video running below so that you can look here on the scheme above. You see the single port system, the jail point is put in so that the inner rim is just above the sphincter. You connect it with the head, having your 3 or even 4 ports inside, and then you can start to do your endoscopic access. And you see the first thing we do is we close the rectum by a purse string, which is important to have a very tight purse string and not have too much folds. So this is important because you are, on the one hand, you are on the tumor side, but also you are intraluminal, meaning you have to do a proper washout. You have to look on a very tight suture. You don't want to have any tumor cell spread. And what we do now, when we made a complete rectotomy, we make a second purse string afterwards. On the right side, you see if we can use, and we can use our finger, this would be a female patient where we just check how close the vagina is. And you very nicely see the muscle fibers of the rectal wall and how close the vagina is here below. So you don't want to harm the vagina at all, especially if there was radiation before. Any small leakage you make, of course, you can suture it, but that would give a more risk that you get a fistula here. So that's the first important part, to have a very good purse string, a close and tight purse string. And then you proceed up and you see how that looks from below. You have the prostate, for example, on the anterior side. You have the angel hair. You very nice see the nerves going into the mesorectum. These are screwdriver vessels accompanying the nerves, and that's very nicely seen from below. You also see perfect the plane, so you can go up. And if what we learned when we started first with cadaver models, that we see the pelvic plexus from below extreme nice, and this is a real life surgery, and you see a lot of these nerves from the inferior hypogastric nerves, which are only seen if you come from below during the surgery. Of course, if you have resected everything after the surgery, you can also see that in the laparoscopic or robotic way from above. But you can imagine if you make nerve-guided surgery, if you're very close to that from below, you can free the nerves and just try to get the specimen in a proper dissection line away and keep them. So this is how it looks when we make a rendezvous maneuver. So we have the 3 screens. The middle one is the one we are looking from below upwards. You see there was the prostate. We just opened up the peritoneum from below. And the same is from looking abdominal side. You see here we lift up the peritoneum And this helping hand from the opposite side makes it very easy to do the operation, to do the connection, and that reduces also your conversion rate. What is about the specimen? We always put it in a bag. So this was in the beginning. We had just a protection foil, but now we always put it in a bag. We make the tension on the bag and not on the specimen. That's the idea, meaning that you have stapled it on the descending colon side as well. So you had your cut on the rectal side, but you also make the dissection on the descending colon and staple it already to be able to put it in a bag and protect the specimen while bringing it out. If it's too large, of course, you can bring it out via the ileostomy side or via Pfannenstiel incision, both is possible. The last thing is the anastomosis, and if you make mainly, if possible, of course, the stapled anastomosis, we prefer the side to end. These are the long anvil options. We prefer to do it similar like this is in the scheme. So we have on the descending colon the anvil. We put a second purse string on the rectal stump on the same anvil to be able to connect it and make a very good, and it's just 1 or 2 centimeters above the sphincter to be able to be sure to have a total mesorectal excision. Of course, if it's lower, you can do your hand-sewn anastomosis as always. So the question is, why should we go for transanal TME, or why even I do a lot of robotic surgery, why do I still stick to the transanal approach? And the question is, do we get better results? Does this technique enable to get better results? And that means questions like circumferential margin, TME quality, distal margin, maybe reduce conversion rate, reduce even leakage rate, achieve a better function later on, or oncological results, and lower morbidity and mortality. And if we can answer one of these questions with yes, without compromising the others, that would make sense. And let me show you, I think we can do that. But for sure, we should be able to implement that safely. So this should be a yes, and this should be a must. So why do I stick to transanal TME? Looking on better complete TME and circumferential margin, you can imagine the pelvis is very wide on the opening above, and it's very narrow. And all the techniques coming from abdominal side, all the anterior, they will deal with the problem to surround the tumor to come to the lowest 5 centimeters or 6 centimeters. And then you are able to cut the colon or the rectum, okay? What you will do during that process, you will do a lot of pressure on the mesorectum to go around the tumor and down. Of course, not with every patient, that's the same risk, but it's the same system. All the techniques coming from above have to deal with that. These are the patients who give the problem. I always call it the ugly trias. You have a narrow pelvis, you have a bulky tumor, you have a fat man, an obese man, and then you have a lot of pressure. And you can imagine that the TME quality in the literature, therefore, gives for these patients a very high risk not to end up with a quicker 1 score. And if we look in the literature, we see in open surgery it's 70 to 85%. In laparoscopy, it's 80 to 90. But with transanal TME, you could reach up to 95 to 100%. Of course, oncological perfection, and that's what we stage the rectal cancer, depends, of course, on the cancer side. And you see the MRI on the left side. There we have 2 positions where we reach the R0 resection, and the circumferential margin may be very good, but there is a point where the circumferential margin on the MRI is 0. So we will have to stay extra anatomical to be able to perform a R0 resection at all, okay? So the larger the tumor, the more narrow the pelvis, the more risky is the circumferential margin. And how good are we in that? You see, that's one of the best studies we have, COLO2 trial. The circumferential margin in the lowest part, in the open surgery, 1 out of 5, and in the laparoscopic part, 1 out of 10 has a positive circumferential margin. And that ends up with a low recurrence rate of 12% versus 5% in open versus laparoscopy. So obvious, the lower, the more difficult it is, and that is what every surgeon knows. The lower we have to go, the more difficult it gets. Remembering Bill Hill saying that this is the left mesorectum, and there was a nice publication by Colin Seages and his group showing that transanal TME. They made MRI after the surgery and had a look on laparoscopy and transanal TME, and they could prove that it was significantly better with transanal TME to make a completeness of the mesorectal excision. That's the one thing. The other thing is all techniques coming from above, they deal with the problem where to cut. So what is the distal resection margin? And you can imagine if that's a bulky tumor, it could be easier to see it. But if it's a small tumor and you come from above through the fatty tissue, you have no idea where you are. Of course, then you want to staple. So if you come from below, you always see the perfect distance. And what we also learned is if we come from above, I grew up in open technique with a TA30 stapler to cut the rectum. But now if you do laparoscopy, it's often more than one stapler, 2 or 3 staple firings are necessary. Even the rectum did not grow over evolution. If you come from below, it's one straight cut, you make your purse string below, so the distal margin, you see the tumor here after radiation, it's very clear where our distal margin will be. We make the purse string below, and then even the opening is below the purse string, so the distal margin is rather clear, even if it's only a small or scary tissue after neoadjuvant treatment. So it's very clear, and it's a right angle dissection you are able to do, and you get the whole fatty tissue of the transanal TME part with you. That is what we want. That was what I mentioned. The more stapling we need, the higher the risk of leakages. There's also a nice publication that as soon as you use more than 2 staplers, the anastomosis leakage rate is much higher. So maybe if we change our technique, and this is what we do, we only have 2 purse strings and perfect donuts, so no crossing stapler lines, maybe we are able to reduce the leakage rate. It will not be 0, and if we look in the literature, we see maybe it's not true, but Antonino Spinelli came up with that technique. He gave an own name. Actually, we did that before already in all the transanal TME cases. There were only 2 purse strings, only 1 circular stapler line, and that would reduce the leakage rate if possible. Okay, no crossing stapler lines, maybe that's a higher risk. So if we look now on the conversion rate, you know that it's about 15 to 17%. And in the beginning, that was the first publication, the classic trial, well, they had a very high number in the rectal cancer group. So there was 1 out of 3 had a conversion to open surgery. The COLOR2 trial had 16%. And the reasons mainly were that, it doesn't work. If you have a helping hand from the opposite side, maybe you can overcome the problem of the huge tumor from below. If we look on the literature, and this is the COLOR2 trial, you see Quirke score, circumferential margin, conversion rate, and also the leakage rate. And then we have a tendency to the first publications of the transanal TME by the group of Patricia Ziller and Antonio Lassi, Colin Sitges. You see here, this is the first 140 from Antonio Lassi, and this is from the registry, the first 720 cases. But the tendency is clear compared to COLOR2. Quirke 1 and circumferential margin is better. Conversion rate and leakage rate goes down, and the conversion rate, even in some groups, goes down to 0. So that's really much better. Of course, that's not a compare to robotic surgery, where also you reach down to 2 or 3% of the conversion rate. If we look on the leakage rate, I will point out that there are publications showing more than 16% of leakage rate, and that depends how you define the leakage. But I think it's more honest to stay with 10 to 15% of leakage rate. That does not mean that you did reoperation on all of them, but 7 to 8% will be more honest. Then it was important to show the short and long-term outcomes, and I only show you a few of the literature. There's a lot of literature, of course, now. This was in 2018, where they compared around 450 to 500 TME cases. If you look on TME quality, circumferential margin, conversion rate, and mobility, and these were comparable between laparoscopy and transanal TME, especially TME, transanal TME, can reduce the ratio of incomplete mesorectum. So this is a little bit better. Also, the positive rate of circumferential margin is a little bit better. Overall, it's comparable. If we look on the first randomized trial, the TALA trial, which was published in Annals of Surgery in 2022, it was about 500 patients in each group, and you see it's similar surgical safety and pathological outcomes in both groups. This was to prove that it's safe, and I think that was important after some years to show that this is a safe technique, and this has to be done in a randomized controlled trial. This was the one group, and the other group was also on the outcomes, surgical and pathological outcomes, about 1,600 patients, 6 randomized controlled trials. That was in October 2023. And you see that also here was proven transanal TME was more likely to have a complete TME, and all the others were similar. Well, I think we should not care too much about the shorter length of stay with transanal TME if it's in the same hospital. So 1/2 a day does not add too much for the patient if they go home a little bit earlier. This was also comparing perioperative and oncological outcomes, looking on the at that time randomized controlled trials, and you see more than 2,000 and nearly 3,000 in one group, and you see TME looks like to be better in conversion rate circumferential margin, and especially positive circumferential resection margin is better, but no difference in all the other perioperative and oncological outcomes. So I think that's important. That it was proved. These are all non-inferiority studies to show that this is not worse. What can we say about quality of life after transanal TME? And we see there are some showing that's a little bit better related to urinary symptoms. That was in 2019. Another also looked on that in 2019, looking on quality of life, LARS, and the prostate scores. And you see that's comparable, functional and quality of life outcomes, because in the beginning, everybody said if we do transanal surgery, it will be worse, but it was proven that this is not. And this is the newest publication from last year. Quality of life also said this is comparable if we look on the functional outcome after transanal TME compared to laparoscopic TME. I don't want to miss that, because some of you know that already, that in Norway in 2019, they stopped to do transanal TME. Because of this study, you can imagine that it's centralization in Norwegian, and all patients with recurrence have to come to some specialized hospitals. So they made a stop after a 3 years period with 110 transanal TME, 20 hospitals doing that, and 4 mainly transanal TME. Actually, there were 20 hospitals, and some of them had very less training, others had very good training. But if there came a local recurrence, only 1 hospital per region is allowed to treat them. So all the local recurrence are coming to some specialized hospitals. That's number 1. And the second, every patient has to be in the national colorectal cancer registry. And what they figured out is that in the transanal TME group, they had a local recurrence of 9.5% within 11 months. And that was a multifocal growth with rapid growing, compared to the 3.4% local recurrence in the other rectal cancer, which were in the cancer registry. So they say with 9.5, that's a no-go. We are not able to do that. It's the technique. Looking on that, multifocal always means there was a tumor cell spread during the operation, and obvious that's not only the technique. What everybody of us who were in the transanal TME group did, we looked on our data, of course, and this is Colin with his number, 3.4 years, nearly the same time period. You see 2% local recurrence after 3 years, and 4 after 5 years. We looked on our group with 180 transanal TME in that period without non-rectal cancer group. It was 3.5 after more than 2 years in median. So we tried to look on that, and the same was of course in other groups, but that's just to prove you that it's not the technique, it's the surgeon doing good or bad. And this is, if we look also systematic review, if it favors something, it would have been overall survival, then it's transanal TME. Disease-free survival, if it's something, it's rather transanal TME, and the local recurrence rate, it's the same. So there is no difference, and that was important to show that transanal TME does not cause higher local recurrence. I think that's important to point out if maybe you know about the Norwegian moratorium. Okay, let's go to the last parts. What about the learning curve? Of course, there is a learning curve for rectal cancer surgery. I think everybody in the room knows that you will not learn rectal cancer surgery within 10 or 15 cases. Nobody of us did. So the number you need, obviously, is around 50 if you do complex cancer surgery. That's true also for esophageal resections, liver resection, pancreatic resections. And you see there was a comparison between laparoscopic, robotic assisted, or transanal TME, and you see the numbers are similar. You will have in laparoscopy around 50. The robot, it depends if you know how to do TME, then you are lower. Or if you have to learn robot and TME, then you are in a higher group. And transanal is also around those 50 cases. So we estimate for complex cancer surgery, you need a teacher, you need a good number in your hospital to reach that learning curve, and that will be around 50 cases. So can we say yes to one of these? And I say, I hope I pointed out for you a little bit. There are, of course, good arguments to say, yes, we can reach better, but of course it's the surgeon who is doing the surgery, and we should be able to implement it safely and not just start a technique because we think that's easier or that's better to do. Maybe it's not, and I like that conclusion, which was done in 2016 for surgeon. We should not forget that the technique of rectal cancer surgery is not easy. If we come from transanal, it's the same anatomy, but in another direction. And the ultimate goal of our technique is to cause minimal morbidity and low incidence of margin positivity. We should not forget that. And the skills, there may be surgeons who will be not able to do that single port surgery from transanally, but they stick to open surgery, and maybe that's better to do good surgery in the way you did it than to jump on a new technique where you will not make the learning curve. I think that's very important to take from transanal. For those of you who are interested, of course, we give a lot of workshops, but I will also invite you to have a look on the colorectal base camp. We built that up during the pandemic, and you have a lot of international faculty, and there are also some videos and some lectures about transanal TME. We cover everything from the right side to the left side to difficult cases, but there is also for transanal surgery, there are some special lectures and videos in that colorectal base camp. You just can Google that colorectal base camp. You have to register, but it is for free, and you can do the CME certification, but you do not have to, but you can pick out some lectures if you want. I will invite you, of course, to the European Colorectal Congress. This year we had the main congress focused on colon and rectal cancer and anal cancer. Next year, we will also provide education village with hands-on trainings, robotic and laparoscopic, and it will be always end of November and beginning of December. I hope I can welcome a lot of you. And for those of you who are interested in hands-on workshops, the largest one is in Davos. That's the Davos Gastrointestinal Surgery Workshop founded by Martin Allgöwer 42 years ago. We have basic, intermediate, and advanced courses with also a colorectal module. So for those of you who are interested, please register, have a look on it. And thanks a lot for your interest.
Thank you, Professor Brunner. We are honored that you are joined us today. And I know you are on call today and you have a lot of operations to do, but we appreciate your participation. So if we have some questions, please.
Thank you for a very nice comprehensive lecture. I just wanted to make sure, are you doing TATME for all rectal cancer cases, or do you select only the expected difficult ones, the obese, the male, the narrow pelvis?
Thanks for that very important question. I think if you want to do a technique proper, you will not learn it on the very difficult cases. So for us, it's approach number one, and we only exclude a few of them. Of course, those you mentioned with the obese and the very difficult, they profit most of the technique, but you will not be able to learn it if you do it only 2 or 3 times a year. So our approach is, and we have around 60 to 100 low or mid-rectal cancer cases, we do all of them transanal if possible.
Okay, thank you, Dr. Brunner, for the very informative lecture. My question actually about the functional outcome. If you compare the laparoscopic approach with transanal approach, even with easy cases, I mean, for those who ultra low rectal cancer, I want to know about your experience about the functional outcome.
We had a publication, I showed you some, and we also had one from our hospital. So looking on that, we figured out that it's mainly the height of the anastomosis. The lower the anastomosis, the worse is the function. On the other hand, if you want to do a TME, you have to be 2 or 3 centimeters above the sphincter, otherwise you will not make the complete TME. And that's more important because we resect the rectum from above or from below, that doesn't matter. 80% of the nerves which are important for the function are coming via the colon, which we have to cut anyway. So there are only the few nerves we can keep from below, which are for the urinary, the bladder, and the sexual function. That are the ones we can keep. And those who go to the sphincter, if we are not having to do an intersphincteric resection, especially, that's a complete one.
Okay, sir. Another question, please, regarding the intersphincteric resection. Do you do usually the intersphincteric resection laparoscopic or transanal approach if you are planning to do the ISR?
So there are two parts of intersphincteric resection. The one is the partial, which means the dissection is on the dentate line. And if you make a complete one, it's the annucutaneous line. That's the definition of intersphincteric resection. I know that people use it in a different way and say, I did a laparoscopic intersphincteric resection, and then I made a stapled anastomosis. But that doesn't mean the intersphincteric resection defined by Eric Rullier, where you say dentate line or annucutaneous line. And this will always be done from below, because then you will do a hand-sewn anastomosis. In an intersphincteric resection, it's always hand-sewn by that definition of intersphincteric. So, of course, then we come from transanal. But this is what I did already in open surgery when I grew up, and we did intersphincteric in Vienna, where one of my teachers has studies with them, Schissel, maybe you know him or read some papers from him. He studied a lot of that intersphincteric on the dentate line, making 2 or 3 centimeters upwards, and the rest was done from above.
Thank you, sir.
Thank you so much. You see, we should stop at a peritoneal reflection. I think after passing learning curve, especially posterior, you can reach up to intersphincteric part by laparoscopy from above, and also for anterior view, like your oncology can done radical prostatectomy and radical cystectomy by a laparoscopy. So that I think only small cases we need transanal total mesorectal excision. My question to you, why this technique is not popular? Like in Egypt, it is a great country. We does not do this technique. And what your comment about Denmark and other country who wanted to stop this technique?
Maybe two things. I agree that you can do a lot of things from above. And you can go down until the intersphincteric part as well from above. But if you think about the picture I showed you, all techniques coming from above have to surround the tumor, have to do a lot of pressure on the mesorectum. There are very good publications showing that in transanal TME, if you make the last 5 centimeters, TME quality is worse because of your high pressure to surround the mesorectum to be able to cut it from below. So I agree, this is only important in the very difficult cases with a larger tumor and the narrow pelvis. But nevertheless, it's true for all of them. So what we want to do is, if you do transanal TME and not only transanal rectotomy, if you do transanal rectotomy, that's not transanal TME because you did nothing of a preparation upwards. If you do the preparation upwards, you work towards the opening pelvis, which makes it much easier if you pull it above and you don't have to surround the tumor, okay? So that's number one. And number two, why it's not that popular, that is, I think, very easy to explain. It's a single port technique in the other direction of the anatomy which you are used to have. So that's not easy. You have to learn first single port technique. You have to learn to suture in single port technique, which is not so easy for many people. If you don't do single port at all, you will not be able to adapt it in a difficult case. So that's why only few groups stay to it, and they have a high caseload, and they do good surgery. But I think that's everywhere. If you do centralization of rectal cancer, the quality will step up, whichever technique you do. And this is just an additional part of your moratorium. And if you want to learn it, well, there's a learning curve of 50 cases. If you drop in the first 10 cases and stop it, well, I agree, that will not be enough. And it's not an easy technique.
Thank you, sir, for your comprehensive lecture. As we know, robotic rectal surgery has advantage over the laparoscopic technique regarding the short and long-term outcome. And if we are particularly in the narrow pelvis, in the mid and lower rectal part. So if we have such great results in the transanal approach, do you think there is no difference in the approach from up between laparoscope and robot, and we can do all cases with robotic surgery, with laparoscopic and laparoscopic abdominal and laparoscopic transanal without need for robot approach?
The advantage of the robots are three things. You guide the camera yourself. You have your free movements of your hands inside with 3 instruments. Okay, this is the advantage. And I totally agree, you can do much more than in laparoscopy, or in other words, more people will be able to do better surgery with the robot. I totally agree. It doesn't change the narrow pelvis. It doesn't change that you have to surround the tumor to come down. So you will have higher pressure on the mesorectum. And what we see is that only with the transanal approach, we reached a higher quality of TME for all the cases, okay? And we had the lowest conversion rate. You can say that's not so important. It's only a few patients. Yes, I agree. And maybe the difference is not too much. So that's why many people did not get to transanal TME, because they said, well, the robot will help me for everything. I don't need it. But you know what happened? I had more than 400 surgeons all over the world coming to my workshops. And in the beginning, it was laparoscopic surgeons wanted to do transanal. Now the robotic surgeons are coming to say, I want to have that additional, because I want to make the lowest part in the difficult. How do I learn that? The lowest part in the very difficult, which are still difficult with the robot. Even if you have your 3 hands free, you have your camera, you have more movements, they stay difficult. And their transanal approach helps a lot, reduces the conversion rate even further, and avoids the high pressure on the mesorectum, because you don't have to surround the tumor.
Okay, Mr. Bruno, thank you for this comprehensive illustrative talk. I have 2 questions. The first one regarding absolute contraindication when we evaluate the patient for the first time. Is there any patient factors like comorbidity, diabetes, uncontrolled neuropathy, pelvic floor disease, and regarding the tumor factor? This is the first one. The second one, is there a role for routine manometric study regarding the pelvic floor or not? Thank you.
Okay, thanks a lot. Very important questions. I will start with the second one. The routine functional testing, so the most important instrument is the finger of the colorectal surgeon. So because I think if you feel the sphincter is good, well, you don't need any additional. If the sphincter is not good and the patients want to have an anastomosis, even if you will do an intersphincteric resection, then it would make sense for legal reason to prove that it was already bad, and you have to tell him, well, probably you will be incontinent after that surgery. But if he wants to have it, well, some patients deal with it and they say, I don't have a problem with incontinence, but I don't want to have a stoma. So if this is very good documented, I think this is okay. You can come back to a stoma always, but you cannot come if you close the sphincter, you will not be able to come back, and that's only for those very low intersphincteric resection. I think that's for the number 2 question. The number 1 question, contraindication. Actually, I think if you start with transanal TME, like if you want to start rectal cancer surgery, the easiest are female patients with a tumor in 8 or 9 centimeter height. That's very good to start to learn low rectal cancer surgery. That makes sense. You will not start with an intersphincteric resection. That's not a good idea. If you cannot operate on a patient because of his comorbidities, well, then that's true for transanal and all of them. Transanal additional has the advantage that you can operate from both sides. So the fastest we did are below 2 hours. And that's very difficult to achieve a proper rectal cancer surgery with a stoma performing below 2 hours, which is possible because you spare 1 or 1.5 hours if you come from both sides. And also the phase where it's difficult is reduced a lot. So that could help. But there are no others. Even we did some where the abdominal part had to be done open, because it was a lot of reoperations. So you were not able to do laparoscopy, but we could come from transanal by an endoscopic method. So we could even have the advantage of the endoscopic TME part. Beside, there was a lot of adhesions and we could not do it from abdominal, and that would be true for the robot as well. I hope I covered your questions.
Professor Brunner, thank you very much for your presentation, and we were honored that you joined us today. Hope we can see you here in Egypt soon. And by the end, I thank you very much for your participation, and see you soon.
Thanks a lot. It was a pleasure, and best wishes to Damanhour.
Thank you very much. احنا معانا دكتورة انجي بس من شركة ايفا، عايزة ترحب بيكم في خلال دقيقتين.
انا مش هطول على حضراتكم، انا عارفه ان الاجنده مليانه والسكادجول مليان، فان شاء الله مش هطول على حضراتكم خالص. الاول انا انجي ابو العينين، شركه ايفا فارما، ميديكال ريبريزنتيف في ايفا. خلاص، حابه بس هايلايت سريعا كده على البورتفوليو بتاعنا اللي ممكن يكون مهم لحضراتكم هنا في المعهد. اول حاجه طبعا احنا الموكسي فلوكس انفيوجن، موكسي تابلت، فورث جنريشن كينولونز. طبعا بنتكلم الاول على السبيكترم بتاعنا، احنا برود سبيكترم انتي بايوتيك، لاست جنريشن في الكينولونز، موكسي فلوكس. طبعا السبيكترم بتاعنا الكفرج جرام بوزيتيف وجرام نيجاتيف واتيبيكال واني روبس. طبعا احنا برود سبيكترم معانا مهم جدا حالات البوست اوبرتيف، ان احنا نحب نكفر ذا موست كومن باثوجين موجوده معانا بعد العمليات. تاني حاجه برضو حابه اتكلم فيها في حالات الانتر ابدومينال انفكشنز، احنا الموكسي فلوكس ليه هاير بنتريشن باور، بمعنى ان كونسنتريشن اوف ذا موكسي فلوكس بيكون في التيشو اعلى من البلازما، وطبعا ده بياكد الهاير بنتريشن باور للموكسي فلوكس، وده بارامتر مهم جدا في الانتي بايوتيك عامه يعني. بلس كمان حالات السكين وشوفت تيسو انفكشن برضو اكيد بتقابلنا الحالات دي كتير، وبرضو الموكسي فلوكس بياتشيف كومبليت ريزوليوشن اوف سيمبتومز بنسبه 93%، سواء في الدايابيتيك فود انفكشن او البوست تروماتيك ووند انفكشن او حالات السيلولايتس. تمام. وبلس كمان حالات الشيست انفكشن، احنا برضو اف دي ابروفد في حالات الشيست انفكشن، سواء الساينوسايتس او النمونيا او حالات البرونكايتس. كده الحالات دي اوريدي احنا عارفه ان هي بعيده عننا شويه، بس احنا برضو اوريدي انديكيتد فيها واف دي ابروفد. بلس كمان حالات الانتر ابدومينال انفكشن، حالات المايلد والمودريت، كومبليكيتد وان كومبليكيتد سكين وسوفت تيشو انفكشن، معانا الدوز لحد 21 يوم سيف، مفيش اي مشكله خالص. بلس كمان حالات بالنسبه للموكسيفلوكس في حالات الشيست انفكشن او الانترا ابدومينال انفكشنز يهمنا جدا نعرف ان الموكسيفلوكس ليه هاي بنتريشن باور، بلس كمان ان احنا بنكفر ذا موست كومن باسج اللي بتقابلنا، طبعا ده ريجاردنج السبيكترم بتاعنا. كمان من الحاجات المهمه جدا التي هاف بتاعتنا، احنا التي هاف بتاعتنا 12 ساعه، طبعا حضرتك انت متاكد ان احنا بنكفر ال 24 ساعه بدوز وانس ديلي. بلس كمان حته الريبيتيشن باور باكد عليها تاني برضو من الحاجات المهمه جدا بالنسبه للموكسيفلوكس. وحته السيفتي كمان، احنا السيفتي بالموكسيفلوكس في حالات الليفر والهيباتيك امبيرمنت مش محتاج اي دوز ادجستمنت على عكس الاذر كينيرون سواء الليفو او السيبرو. بلس كمان حته برضو احنا بنكفر الانيروبس، طبعا دي من الحاجات اللي احنا بنتميز بيها عن الاذر كينيرونز. تمام، ده بالنسبه اول برودكت معانا في البورتفوليو. تاني حاجه طبعا الزوفاترون، ده نيو لونش برودكت معانا، مولكيول اندانسيترون، كونسنتريشن 4 مللي جرام و8 مللي جرام. تمام، هاكد بس على حته ان احنا الاورال الفيلم، طبعا دي من الحاجات السهله جدا للبيشنت، هو ممكن ياخدها في اي وقت، مش هيقعد يدور على مين يديله الفايلز او كده. هو كده كده الاسم ده موجود معانا من زمان از فايل فورمولا، احنا معانا الاو دي اف، ده برضو من الحاجات السهله جدا للبيشنت. سريعا هتكلم على اخر حاجه الدوز. بالنسبه لحالات الكيموثيرابي لو الحاله هايلي هيماتوجينيك، فالدوز بتاعتنا بتبقى 24 مللي جرام، يعني 3 فيلم قبل السيشن بنص ساعه. تمام، بعد كده بالنسبه لو حالات الكانسر كيموثيرابي الحالات المودريت هيماتوجينيك بناخد 8 مللي جرام قبل السيشن بنص ساعه، وبعد كده بنكررها كل 8 ساعات اكوردنج للكيس لحد ما يكمل 32، احنا الماكسيمم بتاعنا 32 مللي جرام. تمام، بالنسبه لحالات الراديو ثيرابي برضو الدوز بتاعتنا لو سنجل هاي دوز فراكشن راديو ثيرابي بناخد 8 مللي جرام، ده قبل السيشن بساعه او ساعتين، وبعد كده بنكرر كل 8 ساعات 8 مللي جرام. تاني حاجه برضو في الديلي فراكشن راديو ثيرابي بتبقى 8 مللي جرام قبل السيشن بساعتين، وبعد كده بنكررها برضو كل 8 ساعات. واخر حاجه في حالات البوست اوبرتيف، لو بوست اوبرتيف عاديه بناخدها قبل الانستيزيا بساعه، بناخد 16 مللي جرام. تمام، ده كده سريعا، يعني حبيت بس هايلايت كده سريعا معاكم على الموكسيفلوكس والزوفاترون. حابه يكون لي فرصه مع حضراتكم هنا ان شاء الله، وان شاء الله برضه هيكون في فولو اب معاكم. وبشكر جدا دكتور ايمن ودكتور رجب ان هم ادوني الفرصه الصغيره دي ان انا بس اتعرف على حضراتكم واشوف حضراتكم النهارده، وميرسي جدا ليكم، شكرا جدا، شكرا، ميرسي.